Brother, we can't hear you. Please unmute your mic.
Thank you, Dr. Mohammed. Thank you, Dr. Serag, for this opportunity. I'm here to present the summary of the previous webinar, Gut Lung Access in the Era of COVID-19, on behalf of Dr. Mona, the one who organized this webinar and organized it perfectly. As we know, the current pandemic, COVID-19 second wave, drives some countries back into lockdown. And as also know, it has huge impact on GI symptomatology, from just anorexia to severe diarrhea, which can occur early in the course of the disease or even be isolated. Gut lung access and all the concepts for new application in COVID-19, I have the honor to present Professor Dr. Alistair Forbes, Emeritus Professor of Medicine of Norwich Medical School, University of East Anglia, UK. I have the honor to present you, sir. So please share your slides.
Very good. Thank you very much. It's a great pleasure to be with you again. Let's just see if we can get the slides working. I don't know if other people have been struggling with them. Let's see if there's a problem. Are you seeing my slides?
Not yet.
Oh.
We have it here.
Oh, you've turned them off. I've got a message saying the host has turned off my slides. Someone at your end has turned them off. Let's try again.
We have your screen now, Dr. Forbes. It's a blank slide now.
It shouldn't be a blank slide. You should have my title slide.
Whiteboard screen, whiteboard just on this here.
I don't know where you've got that from because I don't have such a thing. Okay, let's stop and start again.
Wait. Alistair, if you have,
You're still not seeing my slides?
you can send us a message on the board.
It seems to be working perfectly at my end. And it says that I'm screen sharing and you should be able to see everything that I can see, but you're not seeing anything. Hmm? Is that right? You're not seeing anything?
It's a blank one. Would you navigate forward, see if we can see anything on the next slide, Dr. Forbes?
I'm going backwards and forwards through my slides. I haven't got a blank slide, so I don't know where that's come from.
Are you happy?
Yes, sir. It's a white blank slide there.
If you're having any other application opened on the desktop, please close it. Just the professor is there. Alistair, can we start by Dr. until you adjust your presentation?
Yeah, well, let's just try again.
Okay. Mohamed, okay? Sharaiha.
Yes, sir. I'm here. Yeah. If Dr. Forbes wants to take some time to adjust those technical difficulties, I can try to share my screen.
I don't have any problems at my end. It seems to be working perfectly here. So I think the problem is at your end, not mine. I see my presentation. It seems exactly as it should. You still not seeing my presentation?
Alistair, can you send it to my email and we?
Yeah, sure. Who should I send it to?
Huh?
Who should I send it to?
Send it to me.
Okay.
Presentation, and I share it from here.
Okay, do that.
Okay.
Yep, I will do that right away.
Okay. Hager, Professor Sharaiha will start.
I will present.
All right.
Okay.
So I'm trying to share my screen now. We'll see if that works.
Yes, works.
All right. So good morning, everyone. Good morning from across the ocean. I guess it's evening there in Cairo, Egypt. My topic today is on nutrition in patients with COVID-19. I am one of the transplant hepatologists at the University of Alabama at Birmingham, and it's my pleasure and honor to be here today. I myself is a proud graduate of El-Shazly, and it's really a privilege to be with all of you here today. And since El-Shazly is famous enough, I wanted to let you know about the state of Alabama where I'm at now. So we're located in the southeastern corner of the US. It's a beautiful state that has a lot of beaches and nature scenes, famous for American football teams too, but probably for someone from Egypt like me, the gentleman in the center there, Dr. Harrison, is probably the most famous personality that we know in Egypt. He's the author of the textbook, Harrison Principles of Internal Medicine, one of the first gifts that I got when I went to medical school in Egypt. So he is the former chief of Department of Medicine where I'm at, and the former dean of the school too. So definitely a great place to be at here at the University of Alabama at Birmingham. Now, in June of this year, we became famous for a different matter here in the state of Alabama. We ranked as one of the top 5 states in terms of newly diagnosed COVID-19 cases. And the last number that I got here, October 21st, we had over 1,000 cases diagnosed. And we range in the past month between 800 to over 1,000 cases. Now, my talk today will focus on the items that you see there on the list. And before I get into specifics on nutrition to our patients, I just wanted to go through an introduction and a global perspective of that disease. So COVID-19, as you're well aware, is caused by the SARS-CoV-2 virus. And this is an RNA beta coronavirus. It attached to the ACE2 receptors, and those are found throughout the GI tract and also in the cholangiocytes and hepatocytes and the liver. The symptoms range from anorexia, diarrhea, nausea, and vomiting to abdominal discomfort, and quite a few reports on isolated GI presentation of the disease. So before we get into our patients that we take care of, I thought it would be a good idea to look at the effect of that disease on nutrition globally. So up to 500 million people are pushed to poverty because of that disease, and up to 130 million people are at risk of starvation. And those are in countries that are around us in our region, in the Middle East and in Africa, and definitely in developed countries too. So essential food prices are going up. So this is a disease that's going to be beyond our clinics and hospitals. It would have a big impact globally. So let's talk about the disease and its relationship to malnutrition. I thought of that as a vicious circuit, really, where patients that have malnutrition and are susceptible to developing muscle wasting and sarcopenia are at a higher risk for developing COVID-19. And definitely they tend to need hospitalization, longer stay in the hospital and in the ICU. Well, that in itself, the hospitalization in the ICU would lead to further muscle wasting and malnutrition. So it's really a vicious circuit and a feedback loop that contains the malnutrition and the disease itself. So how do we approach patients in terms of their nutritional needs? So we'll talk about the non-critically ill patient first, the one that's managed at home or in the hospital, not necessarily in the ICU. So definitely oral nutrition is preferred to maintain the gut barrier. So the bacterial translocation process increases in patients that are not fed enterally. So nutritional supplement can be started if your patient is not meeting their goals of nutrition within the first 2 days. And then you should continue that to provide them at least over 400 calories and more than 30 grams of protein for a month during their illness until they keep up with their PO intake. And definitely if the patient is unable to keep up with PO intake entirely, you can consider nasogastric tube feeding. Now, it is debatable if the post-pyloric feeding tube is necessary, whether you leave it in the stomach or push it further distal to post-pyloric position. I think it might be valuable in patients that have gastroparesis. Now, in the patients that are critically ill in the ICU, you should start early enteral nutrition in those patients at a low rate, maybe 10 to 20 ml per hour of your supplement. Continuous feeding is preferred to the bolus method. And the reason for that is the bolus method would lead to more issues with diarrhea. And you have a high protein goal for those patients, 1.2 to 1.5 gram per kilogram per day. Now remember, the average person that's healthy needs 0.8 gram per kilogram. So those patients, when they are ill, they are in a catabolic state and they need more protein to battle that sarcopenia and malnutrition. And the goal of calories is 20 calories per kilogram per day. And this is reminiscent of our cirrhotic patients that have decompensation. They do need a high protein goal as well. Now, why is that important? Patients that have frailty and sarcopenia, they have higher risk of mortality. And also remember to optimize the control of the blood glucose in those patients. So depend a lot on basal insulin, so your staff would not have to go in and out of the room frequently to cover the patient with insulin if the blood sugar is high. Now, delicately manage the fluids and electrolytes, because as we know, those patients are at risk of developing acute respiratory distress syndrome, or ARDS. And those patients, you want to keep them on the dry side. Usually, if they get wet, if you will, then they have higher risk of poor oxygenation. The TPN, or total parenteral nutrition, is always a last resort in our patients because it has higher risk of infection and complications and further devitalization of the gut barrier, as we mentioned before. Now, I took this slide from the ESPEN guidelines, and it summarizes what we talked about in the past few minutes. So first, if you start on the top there, you check for malnutrition. And then if you go down to your left side on the screen to number 2 here, those are the patients basically that are on the floor, not in an ICU setup. So assess their nutritional status, supplement them with vitamins and minerals, and we'll elaborate on that as we go forward. And then encourage regular physical activity for the patient and give the patient oral supplement if they cannot keep up with their oral intake. And then if you move to the right side of the screen there to number 7, so those are the patients that are not intubated in the ICU. You start with enteral nutrition. And then if the patient needs a feeding tube, that's reasonable to pursue. And then assess the patient for TPN as a last resort, as we mentioned before. And then if your patient has dysphagia, that's on the last button there on number 10, then you can always place a nasogastric tube for feeding for those patients. Now, some issues may arise during feeding, and I wanted to spend a couple of minutes talking about that. So the first issue is, as you know, patients that have COVID-19 are quite frequently put in prone position in the ICU. So there is a concern sometimes that this may increase the intra-abdominal pressure. Those patients are on high doses of sedatives and paralytics. Would that affect their motility and their gastric empty? It's unclear, and actually they are not at increased risk of GI or pulmonary complications if you decided to feed them. So I would advocate for early low-rate feeding for those patients and consider holding the feeding maybe for an hour or so prior to changing of the position. Now, other issues that are related to motility include nausea, vomiting, or ileus, delayed gastric emptying. You can consider prokinetic agents. We use erythromycin if the QT interval is okay. We use metoclopramide for a short period of time. And then we mentioned before that you may consider post-pyloric feeding for those patients that have delayed gastric emptying. If you have a patient that develops abdominal distension, reduce the rate and the volume and continue to monitor that patient. Diarrhea can happen, and in those patients, you can move to a semi-elemental formula or pre-digested formula. Next, we'll talk about vitamins because that's the hot topic that your patients will ask you about. As a disclaimer, all of those things are still in the experimental and trial phase. No solid evidence that they would help in COVID-19 management. But vitamin C is a great antioxidant. It protects against coronavirus infection in avian models. So you can also look at evidence from common cold where it reduced the severity and the duration of the disease. In the US, we had conflicting data about the use of IV vitamin C for treatment of patients who are septic in the ICU. The bottom line is it's unclear what the impact is on COVID-19, but it's a safe supplement to use. Next is zinc, and you have a variety of food there that contains zinc. It is important for the formation of antibodies and white blood cell count, and also it leads to if you're deficient on zinc, you can have increase in your inflammatory markers, so the cytokines and the TNF alpha. And the closest evidence to COVID-19 is that it inhibited the replication of SARS-CoV-1 in vitro. So there is a promise there that it may help with COVID-SAR2. And then the other thing is, if you look at rhinovirus or common cold, it did reduce the severity of the disease also. Now, zinc itself can cause mild GI side effects, so you gotta be aware of that when you recommend it or if your patient takes it. And then, as we all remember, zinc and copper are competitive in the body. So if your patient is diligent and using zinc every day, they are actually at the risk of copper deficiency. And then it's being evaluated also in trials for management of COVID-19. Next is vitamin D. Vitamin D is actually an immunomodulator. You can look at it this way, and it inhibits the cytokines, and it also inhibits the antigen-presenting cells. So it provides some promise in management of a disease like that. And in fact, if you look at COVID-19 in calves, in animals, so that's the closest example that we have, the deficiency of vitamin D was associated with increased risk of COVID-19 infection. It is unlikely to cause harm. Now, it won't be fun without talking about foods and herbs. That's, again, another thing that patients will ask us about. So the list is long. I chose some of them. Turmeric is believed to have an anti-inflammatory effect. We have some utility in IBD. Ginger has an anti-emetic effect. Garlic and onions might be antimicrobial. There is a debate about elderberry and honey that they may agitate the immune system. Beets may increase the oxygenation. I honestly look at those supplements or dietary modifications and say, if they won't harm, it's probably healthy to use them with the caution about the elderberry and the honey, as we said. So I do not have objection. You kind of have to choose your battles when you're talking to your patients. So if it comes to drinking or gargling with chlorine, I'll object to that. But if they gotta eat garlic or onions, that's fine. Now, this is a summary slide of what we talked about. And as we said, there is a dynamic feedback loop between COVID-19 and malnutrition. And the use of the vitamins and supplements is still investigational. No solid data yet, but it has low potential for harm. Early nutrition is preferred to maintain the gut barrier, as we said, and prevent that bacterial translocation. And TPN should be left as a last resort. And remember that we presented numbers in the beginning that patients, not the ones that we take care of only, but people that we know in our communities are going to be hungry and malnourished. We're really all in this together, and we should put a lot of effort into taking care of those who are vulnerable and needy amongst us. With that, I'll show some of my references here, and I wanted to thank you again. It is a privilege and an honor to be here, and I look forward to more meetings. Thank you.
Thank you, Dr. Mohamed. It's our honor to be with us. And thank you for this summary about the usage of vitamin and supplements. And now we will move to Dr. Alistair.
Right. Do you want me to try again with my slides, or are you going to do it from your end?
I think I will share it. The same problem, sir.
You still can't see them?
Yes, it's blank. This blank slide again. So
I don't know where it comes from. Do you just want to project them at your end then, and I can just say when to change the slides?
Okay.
Okay, so by word of introduction to say that I'm very pleased to be with the group, and sorry that I can't be with you in person on this occasion. If we go to the next couple of slides, I moved through this quickly. I've moved largely now to Tartu in Estonia. And if we go to the next slide and the next slide, we'll get on with the talk. So next slide, yeah. Background to the gut and the lung. Is there actually a gut-lung axis? We know about these different axes because we know about endocrinology and the obvious hormonal links between different distant parts of the body. And we've understood that in gastroenterology for many years because of the links between the intestine and the liver and the importance of the enterohepatic circulation. And we've understood that more recently in recognition of the gut-brain axis, in looking at obviously the functional gastrointestinal disorders, things like irritable bowel, where we think that the brain has an effect on the gut symptoms and the gut symptoms have an effect on the brain. And then more recently, we've begun to realize that there are other sorts of gut-brain axis interactions with the degenerative brain disorders, such as Parkinson's and dementia. So it's not...
معك العنوان؟ ها؟
Alistair, we hear you.
I'm hearing strange voices. Is everything all right?
Please continue.
So we have lots of logic for thinking about it. We go to the next slide. And the next slide. So are there physiological links between these systems? Does the disease of one system affect the other? Are there diseases in which both organ systems are involved? And could any of that, if it exists, be relevant to COVID-19? Next slide. First of all, is the gut microbiome, which we know a little bit about, relevant to lung disease? In the gut, we've got approximately 10 times as many microbiota as we have human cells, lots of different types of microorganisms, some of which, if they get into the bloodstream, are pathogens. Might some of these cause lung disease, and may they be relevant, particularly the gut fungi, in the context of asthma? The answer is probably yes. Next slide. Is there a lung microbiome analogous to the gut microbiome? Well, historically, we've thought of the lung as being a sterile space, but that's in fact not true. The biomass in the lungs is substantially lower than in the gut, but we do see somewhere between 10 and 100 bacteria per 1,000 human cells. So this is a 300-fold difference from the prevalence of microorganisms in the gut, but it's not zero. And interestingly, the composition of that microbiome in the lung is very dependent on colonization from the oropharynx and the upper airway, and almost certainly from the gut more generally. Normally, the lungs are kept fairly clean by coughing and mucociliary clearance, but there are other factors that are also important, including the host immune system and factors like pH and the local oxygen concentration, which become important in disease. Next slide. Next slide. In the gut, in the lung, the predominant commensals are the same as in the gut, and the predominant fungi are usually environmental ones. There's not really a great deal known about any viruses in the lung. Next slide. It does seem, though, that there's an internal microbiome lung axis. So in the same way that we see the microorganisms all interacting with the gut, we also can see the microorganisms interacting with the lung. There is clear evidence of the microorganisms interacting with each other and potentially interacting with the lungs in terms of respiratory disease. So we can demonstrate, for example, and these are all in man, that Candida stimulates the growth of Streptococcus. Streptococcus in turn increases the amount of biofilm that Candida forms. And maybe unsurprisingly, Candida pathogenicity is enhanced by Streptococcus. It's not just those two organisms, there's also clear evidence for an increased growth of Aspergillus when there's Pseudomonas present. Next slide. So we can see that there is also an interaction between the gut and the lung. It is the neonatal diet that determines the initial composition of the lung microbiota. So it's not just what's in the mouth, what isn't coughed out, but an interaction between the microorganisms in the gut and the microorganisms in the lung. And that becomes even more important when we look at disease. So in the young patient with cystic fibrosis, there is gut colonization before there is respiratory tract colonization in newborn infants. So all these are bugs that are commonly found in the gut, and they subsequently appear in the lung. They are not there when the baby is born. And the gut and the lung prevalence and the quantities are highly correlated over time, typically with that 300-fold ratio that I told you about before. So many, many more in the gut, but proportionally, if the gut numbers go up, so do the lung numbers, and the distribution, the different types of organisms are also very similar. And it's not just in cystic fibrosis, it's also true after severe infection, any sort of severe infection. If you have sepsis, the lung microbiota are strongly enriched with gut bacteria, such as Bacteroides. Next slide. I mentioned before asthma. We know, for example, that Aspergillus is an important exacerbating factor for asthma. And if you have intestinal fungal dysbiosis, so if the fungi in the gut are altered, that can alter the activity of asthma in an animal model. And that appears to be true even when none of those fungi are actually in the lungs. So there is a link between the gut and the lung in terms of the organisms that are in the gut and get to the lungs, but it can also be true when there are organisms in the gut that are not in the lung, but there is some additional form of mediation, some sort of connecting pathways between the gut and the lung. And the mechanisms suggested include cytokine release, but are probably not limited to that. It's also true that the lung microbiota may affect the gut, and particularly, and begins to be relevant to COVID-19, influenza infection triggers an increase in gut Enterobacteriaceae and decreases in lactobacilli and lactococci. And if you give lipopolysaccharide, which is a pretty destructive thing, but analogous to many respiratory infections, administer that to the lung, and that causes a substantial alteration of gut microbiota. So no lipopolysaccharide put in the gut, just in the lungs, but a substantial alteration of gut microbiota. So it's quite clear that in both directions, if you change the microbiota in one place, you change the behavior and function of the other organ. So there are clear potential relevances there to infection with a new virus. Also, we know a little bit about the gut-lung axis in acute bacterial respiratory infection. lung microbiota protect against acute respiratory infection caused by some pathogens. So, for example, the prevailing background healthy microbiome in the lung protects against strep pneumoniae and against Klebsiella pneumoniae. The effects are probably largely via the colony stimulating factors and by enhanced neutrophil recruitment. So this is again similar to what we see in the gut. We see a gut that's healthy because we've got the right bugs there, and those bugs protect us against gastrointestinal infection. The right bugs in the lung protect you against respiratory infection. Next slide. And if we look at germ-free mice, we find that they have increased morbidity and increased mortality from those standard acute bacterial respiratory infections. And broad spectrum antibiotics cause worse outcomes from subsequent acute bacterial respiratory infection in those same mice. And it appears that that's a problem largely down to the combination of neutrophil function and macrophage function, both of which are abnormal, they're impaired. So the macrophages are not working normally and the neutrophils are not working normally. Next slide. If we turn then to viral respiratory infection, there's not very much human data. What we do know, however, is that oral antibiotics reduce the host immune response to influenza. So patients that have had oral antibiotics and who are then exposed to influenza virus do not produce the normal host immune response. Doesn't mean they automatically die from it, but they get a more severe illness than they would have had they had their normal lung microflora protecting. Interestingly, and this is mouse data, now this is not human data, but if you put a mouse on a high fiber diet, that will protect it from fatal influenza. Now that's a rather surprising observation, but it's an observation that's clearly demonstrated by carefully done research. And it appears there that the difference is again in the macrophages and the neutrophils, but in the opposite direction. So here we're looking at a positive effect of short chain fatty acids on CD8 cells. So here we're seeing a positive effect of lymphocytes. Next slide. So clearly there are some good reasons for thinking that the gut and the lung are interacting in the context of COVID-19. We've already heard many of the important clinical features of COVID-19 as far as the gut is concerned, and I don't need to say any more about that. You've heard very nice things there already. We haven't got concrete evidence for fecal-oral transmission. We can see viral RNA in the stool, but it's not yet clear that it can actually cause a primary infection. But what we are seeing is increased morbidity and mortality in certain populations, which are exactly the populations who have abnormal gut microbiota. So this hypothesis came from a group in Turkey. They suggested that increased permeability increases the chance of secondary infection and therefore of multiple organ failure. It's an interesting hypothesis. It's not yet supported by any data, but it would make some sense if there is increased permeability leading to translocation of the virus. But what I've been telling you already is that there doesn't need to be translocation of the virus from the lung to the gut or from the gut to the lung, because there are channels of communication through the microbiota and other systems, such as cytokines, that would allow that to happen, even if there wasn't increased permeability. Next slide. So we've got high-risk populations with increased, or at any rate, abnormal intestinal biodiversity. We've got increased risk, which is multifactorial, but could be closely aligned to established features of the gut-lung axis. Primary viral infection we know to be aggravated by less effective monocytes and a less effective CD8 cell response. We also know that secondary bacterial infection, so you get your primary viral lung infection, then on top of that, you get a bacterial infection. And it's often that kills people. You've heard about the cytokine storm. That's when the cytokine storm is happening. It's the secondary bacterial infection. It's not the virus on its own, most probably. So we're dealing, first of all, with a lymphocyte problem, and then with an alveolar macrophage neutrophil problem. Now, the key thing there is that all of those things are open to manipulation. And if they're open to manipulation, that also means that there's potential there for therapy. So this is a very exciting area for exploration and could lead us in some quite interesting directions. The next slide, please. This just summarizes the title, but also gives you an opportunity to make a note of my email address, because it's obviously rather difficult to take questions in a normal way in this context. So apologies that the slides didn't work smoothly to begin with. I don't know why that was. It's still looking perfectly okay on my screen here, but I hope you've been able to see the key messages, and I'd be very happy to answer any questions there are now, if there are any. And thanks again for the kind invitation.
Thank you, Dr. Forbes, for your attendance and for being with us.